Welcome to the deep dive. We're here to unpack complex topics and give you that shortcut to being genuinely well informed. Today, it's sepsis syndromes, really high stakes stuff in clinical care where, every single decision can be life saving. But before we really get into the thick of it, let's just take a moment, a quick pause, just for you. Go ahead, take a breath in, hold it for a second, and now exhale slowly. Good. Now, think of just one thing you're truly grateful for right now. Could be your progress, maybe your support system, or hey, just having this time today to focus and study. Just let that feeling, that gratitude settle in for a moment. There's actually research showing that starting from this place of gratitude and presence, it really enhances focus and memory. So as we tackle sepsis, honestly, one of the most critical topics out there, let's prime our brains to really soak up all the insights that are coming up. And hey, before we jump right in, if you find these focus reviews helpful, maybe for your NAPLEX prep or just your coursework, please think about subscribing to the channel. It really helps us grow this learning community and bring quality, compassionate pharmacy education to more students just like you. Okay, so sepsis. It's not just an infection, is it?
No, not at all. It's more like the body's overreaction to an infection, a really dangerous overreaction.
Just an overreaction. Okay.
Yeah, it's this whole continuum. Systemic inflammation, hypoperfusion, meaning not enough blood flow, which then leads to tissue injury and ultimately organ failure.
Wow. So our mission today really is to equip you with the crucial knowledge for diagnosing and managing sepsis. We've pulled this directly from expert sources so you can feel more informed, more confident. Whether you're prepping for an exam or just curious about these urgent interventions, this deep dive should help you grasp the critical concepts quickly. Hopefully help you contribute to better patient outcomes.
And that overreaction point you made, it's absolutely key. Sepsis development is, well, it's incredibly complex, lots of factors involved. But inflammation is right at the core.
Yeah.
Normally, inflammation is protective, right? But in sepsis, that pro-inflammatory response just goes into complete overdrive. It starts causing harm itself.
So the protector becomes the attacker, in a way.
Exactly. And the way it presents clinically can vary so much from patient to patient. And the complications, they can be severe.
Like what kind of complications are we talking about?
Well, things like DIC, disseminated intravascular coagulation. That's where the body paradoxically forms clots and bleeds excessively. It's chaotic.
Oh, wow.
Or ARDS, acute respiratory distress syndrome, which just devastates the lungs. Then there's AKI, acute kidney injury, and significant hemodynamic compromise, basically. The circulatory system just can't keep up, can't deliver enough oxygen.
And these complications are often what makes sepsis so deadly.
They're often the leading factors in mortality, yes.
Yeah.
It's a cascade.
Okay, so let's unpack this with some solid definitions. Get everyone on the same page. When we talk about infection here, what exactly do we mean?
In this context, infection is the inflammatory response your body mounts when microbes invade tissues they shouldn't be in.
Okay. And terms like bacteremia or fungemia.
Those simply mean there are viable bacteria or fungi actually present in the bloodstream. Doesn't automatically mean sepsis, but it's a key finding.
Got it. So building on that, what's the official definition of sepsis itself? The current one.
Right, the Sepsis 3 definition. It's defined as life-threatening organ dysfunction caused by a dysregulated host response to infection.
Life-threatening organ dysfunction,
Yeah.
dysregulated response. Okay. And how do we spot that organ dysfunction?
That's where the SOFA score comes in the Sequential Organ Failure Assessment Score. We identify sepsis by an increase of 2 points or more in the SOFA score from the patient's baseline.
2 points or more. And SOFA looks at multiple organ systems.
Yes, it assesses respiratory function, coagulation, liver function, cardiovascular status, central nervous system, and renal function. It's like a quick systems check for failure.
And I've heard of QSOFA too. Is that different?
Yeah, QSOFA or Quick SOFA is a simplified bedside tool. Good for rapid assessment outside the ICU, maybe in the ER or on the ward.
Okay. Simpler how?
It just uses 3 variables. Respiratory rate is at 22 or higher, systolic blood pressure is at 100 or less, and altered mental status.
3 things. Easy to check.
Exactly. If a patient has 2 or more of those criteria, it's a big red flag for potential sepsis. It means you need to investigate further, probably calculate the full SOFA score, and monitor closely.
Okay. That clarifies sepsis. Then what about septic shock?
Septic shock is a really critical subset of sepsis. These are patients who, despite getting adequate fluid resuscitation, remain hypotensive. Their blood pressure is still dangerously low.
So fluids are enough?
Right. They specifically need vasopressor therapy medications to constrict blood vessels just to maintain a mean arterial pressure, or MAP, of 65 millimeters of mercury or greater.
MAP of 65, okay. Is that the only criterion?
No, there's a crucial second part, and they have a serum lactate level greater than 2 millimoles per liter.
Ah, lactate. Why is that so important?
High lactate, especially after fluids, is a critical sign of hypoperfusion. It means cells aren't getting enough oxygen, and they're switching to anaerobic metabolism, producing lactic acid as a byproduct. It indicates ongoing shock at the cellular level.
Got it. So hypotension needing pressors and lactate over 2, despite fluids, that's septic shock.
Precisely. And sometimes you'll hear the term multiple organ system failure, or MODS, that just describes a situation where several organs are failing and require intervention.
Okay, that's a clear progression. Now, who are the usual suspects? What kind of bugs usually trigger this whole mess?
Well, gram-positive bacteria and gram-negative bacteria are definitely the major players. Think staph, strep, E. coli, Klebsiella, Pseudomonas.
The common ones?
Yeah, but it's really important to remember it's not just bacteria. Fungal species like Candida can cause sepsis, especially in immunocompromised patients or those with central lines. And even viruses can trigger it sometimes.
Right. And where do these infections usually start?
The most common sources are the lungs pneumonia, is a big one, the gastrointestinal tract, like infections in the abdomen, the genitourinary system, so UTIs, and also primary bloodstream infections, maybe from an infected IV line.
Makes sense. And who's most at risk for developing sepsis if they get an infection?
Several groups are at higher risk. Extremes of age, so the very young and the elderly. Patients with cancer, anyone with immunodeficiency, whether from disease like HIV or from medications.
Like transplant patients.
Exactly. Also people with chronic organ failure, kidney failure, heart failure, liver failure. Interestingly, there seem to be some genetic factors, too. Being male, non-white ethnic origin in North America seems to correlate with higher risk in some studies.
Interesting.
And definitely patients who already have bacteremia are at high risk of it progressing to sepsis. Plus, there are even specific genetic polymorphisms linked to immune regulation that can predispose people. It's complex.
It really is. Okay, this is where it gets really interesting, because now we're talking about action, the urgency. With sepsis, time is just critical, isn't it?
Absolutely critical. It's often compared to treating a heart attack or a stroke. Time is tissue. Time is life.
So what are the immediate first steps diagnostically?
Okay, first, you need to try and identify the bug. So, microbiologic cultures, blood cultures are key, but also cultures from other suspected sites like urine or sputum. These should ideally be obtained before starting any anti-infective therapy.
Before antibiotics. Okay.
But, and this is probably one of the most critical takeaways for anyone listening, you cannot delay starting antibiotic therapy while you wait for those culture results. Absolutely not.
Why not? How long do cultures take?
Well, initial results might start showing growth in, say, 6 hours maybe, but getting definitive identification and sensitivities can take 24 or 48 hours, sometimes longer. Sepsis progresses much, much faster than that. Waiting is not an option.
Okay, so get the cultures quickly, but start the antibiotics immediately after.
Immediately after drawing the cultures, yes. You might get rapid identification from a positive blood culture within maybe 1 to 3 hours nowadays with newer technology, which is great for refining therapy later, but you can't wait for that initial hit. And remember, negative cultures don't rule out infection either, especially if antibiotics were given beforehand or it's a localized infection.
That's such a crucial point. So the goal of treatment is reducing morbidity, reducing mortality, and speed and appropriateness are everything.
Everything. Early intervention saves lives. And the first big intervention usually is fluid resuscitation. It's proven to decrease mortality.
Fluids first. Okay, so when a patient hits the door, suspected sepsis, what's the fluid plan? Is there a magic number?
There is a key starting number to remember. The recommendation is to administer at least 30 milliliters per kilogram of ideal body weight.
30 milliliters per kilogram.
Yes, of intravenous crystalloid fluid. And that needs to happen within the first 3 hours of recognizing sepsis or septic shock. That's part of that critical hour 1 bundle concept, though sometimes it takes the full 3 hours to get that volume in.
Okay, 30 milliliters per kilogram within 3 hours. What kind of fluids? Crystalloids, you said.
Yeah, crystalloids are the go-to first line. Things like lactated Ringer solution or 0.9% sodium chloride normal saline. Sometimes colloids like 5% albumin are used, but crystalloids are generally preferred initially because they're effective and, frankly, cheaper.
Is there a preference between lactated Ringers and normal saline?
There's actually a growing preference for balanced crystalloid solutions, like lactated Ringers, over unbalanced ones, like normal saline.
Why is that?
because large volumes of normal saline can lead to hyperchloremic metabolic acidosis, too much chloride, which can worsen the patient's acid-base balance. Balanced solutions are less likely to do that.
Good point. Are there any fluids we should actively avoid?
Yes, definitely. Hydroxyethyl starch solutions, HES or HETA starches, are a no-go in sepsis now. They've been linked to increased risk of kidney failure and bleeding, so avoid those.
Okay, avoid starches. Any other cautions with fluids? Can you give too much?
Absolutely. Fluid overload is a real concern, especially in patients who might already have issues like congestive heart failure or ARDS. Crystalloids distribute widely in the body, not just in the blood vessels, so large volumes can lead to edema, including pulmonary edema. You have to be cautious.
So after that initial 30 milliliter bolus, what then? Do you just keep pouring fluids in?
No, not necessarily. After that initial resuscitation period, if the patient still seems hypovolemic, signs of poor perfusion persist, you might give a fluid challenge. That's typically 500 to 1,000 milliliters of crystalloid given relatively quickly.
A challenge dose.
Right. And then you carefully assess their response using dynamic measures. Things like passive leg raises, changes in pulse pressure, or stroke volume variation if they're intubated. You're looking for signs that giving more fluid will actually improve cardiac output and perfusion, not just cause overload. It becomes much more tailored after the initial bolus.
Okay, let's pause for a quick knowledge check here. What is the minimum volume of fluid recommended in the initial sepsis resuscitation? If you were thinking 30 milliliter per kilogram of IV crystalloids, you're spot on. So fluids are crucial. But what happens when that initial volume resuscitation, even with challenges, just isn't enough to get the blood pressure up and restore organ perfusion?
That's exactly when we move to the next critical step, initiating vasopressors and sometimes inotropic agents.
Vasopressors, drugs to raise blood pressure.
Correct. And inotropes are drugs that increase the heart's contractility. The goal is to restore adequate arterial pressure and tissue perfusion.
Do you need a central line right away to start these? Getting one can take time.
That's a great practical point. Ideally, yes, vasopressors are given through a central venous catheter because they can damage peripheral tissues if they extravasate, leak out. However, in an emergency, you can initiate them through a well-functioning peripheral IV line, especially in a large vein, while you're working on getting central access. You just need to monitor that IV site very closely. Speed is key.
Good to know. Okay, so which vasopressor do you usually start with?
The recommended first line, the go-to initial vasopressor for septic shock that hasn't responded adequately to fluids, is norepinephrine.
Norepinephrine, the workhorse.
It really is. It has both alpha-adrenergic effects, which cause vasoconstriction and raise blood pressure, and some beta-1 effects, which can help maintain cardiac output. It's generally effective and has a relatively good safety profile compared to some others.
What if norepinephrine alone isn't enough to reach that target MAP of 65?
A good question. The next step is often to add vasopressin, usually at a fixed low dose, like 0.03 units per minute. Vasopressin works differently on V1 receptors, and adding it can sometimes allow you to decrease the norepinephrine dose. It's an add-on therapy.
Add vasopressin, but not use vasopressin by itself first.
Correct. Low-dose vasopressin is not recommended as the single initial vasopressor. Norepinephrine holds that spot.
Okay. What if even norepinephrine plus vasopressin isn't cutting it? Any other options?
Yes. For patients still refractory, you might consider adding epinephrine. Epinephrine has potent alpha and beta effects. Or potentially dopamine, though dopamine is used less commonly now as a primary pressor in septic shock.
Why is dopamine less favored?
Mainly because studies suggest it carries a higher risk of arrhythmias, like tachycardia or atrial fibrillation, compared to norepinephrine. It might have a niche role in patients with bradycardia and low arrhythmia risk, but generally NE is preferred. Epinephrine also carries a higher arrhythmia risk than NE.
So NE first, maybe add vasopressin, then maybe consider epinephrine. What about phenylephrine?
Phenylephrine is a pure alpha agonist. It constricts blood vessels but doesn't really help cardiac output. So it's generally not recommended in septic shock unless there are very specific circumstances.
Like what?
For example, if norepinephrine is causing severe tachyarrhythmias. Or in rare cases where you know the patient has very high cardiac output but is still hypotensive. Or maybe as a last-ditch salvage therapy when other combinations aren't working, but it's not a primary agent.
Gotcha. And what if the problem seems to be more with the heart muscle itself, like poor contractility?
Ah, yes. If there's evidence of myocardial dysfunction, maybe seen on an echocardiogram, or suspected based on persistently low cardiac output, despite adequate fluids and vasopressors, then you'd add an inotropic agent. Dobutamine is the usual choice here.
Dobutamine for heart squeeze.
Exactly.
Yeah.
But remember, all these agents are powerful. They need very careful, slow titration. You're constantly watching the MAP, signs of perfusion like urine output and mental status, and also watching for side effects.
What kind of side effects?
Tachycardia, arrhythmias, sometimes even myocardial ischemia, because they increase the heart's workload and oxygen demand. And you absolutely have to keep reassessing the patient's fluid status. You can't just rely on pressors if the patient is still volume depleted.
Constant reassessment. Okay, quick question for the listeners again. Which drug is typically considered the first-line vasopressor for septic shock? And the answer we just covered is norepinephrine.
All right, let's shift gears a bit. We've talked fluids, we've talked pressors. What about the infection itself, the antibiotics?
Absolutely critical. This is another pillar where speed is paramount. The guidelines strongly emphasize administering broad-spectrum anti-infectives, ideally within the first hour of recognizing sepsis or septic shock.
Within the first hour. Why so fast?
Because studies clearly show that early, appropriate empiric antibiotic therapy significantly decreases mortality. Every hour of delay in getting the right antibiotics on board in septic shock is associated with worse outcomes.
Okay, so you hit them hard and broad right away, empiric therapy.
Exactly. Empiric means you're making your best educated guess about the likely pathogens before you have culture results back. This often means using combination therapy initially to cover the most likely culprits, including resistant organisms if suspected.
Combination therapy to start. Often, yes, for broad coverage. However, it's important to know that once a specific pathogen is identified and, its sensitivities, de-escalating to targeted monotherapy is usually just as effective and preferred as it reduces side effects, cost, and the risk of promoting further resistance.
Makes sense. So how do you choose that initial empiric regimen? It sounds complicated.
It involves considering several factors. What's the suspected site of infection? Lungs, urine, abdomen. That narrows down likely pathogens.
Okay. Source matters.
Definitely. Also, was the infection acquired in the community, or is it nosocomial hospital acquired? Hospital bugs tend to be more resistant.
Right. Community versus hospital.
Then you consider the patient themselves. Are they immunocompromised? Do they have specific risk factors? Allergies, recent antibiotic use, what does their past medical history tell us? Cost is a factor too, of course. And critically important is local antibiogram data.
Antibiograms.
Yeah, hospitals track the susceptibility patterns of bacteria isolated locally. Knowing your local resistance patterns is crucial for making good empiric choices. You have to know what drugs are likely to work in your specific environment.
So it's tailored. Can you give some examples? Like what might you use for pneumonia versus a UTI? Just general ideas.
Sure. For, say, community-acquired pneumonia that's severe enough to cause sepsis, you might use a third-generation cephalosporin like ceftriaxone, plus a macrolide like azithromycin, or maybe a respiratory fluoroquinolone.
Okay.
But if it's hospital-acquired pneumonia, especially ventilator-associated pneumonia and septic shock, you're thinking broader, maybe an anti-pseudomonal beta-lactam, like piperacillin tazobactam or cefepime or meropenem, potentially, plus an agent covering MRSA like vancomycin or Linezolid, depending on risk factors.
Big guns for hospital pneumonia. What about a UTI?
Community-acquired UTI causing sepsis might get ceftriaxone, or maybe ertapenem if resistance is a concern. Hospital-acquired UTI, again, you're probably reaching for broader agents like piperacillin tazobactam or meropenem, maybe an aminoglycoside, depending on local data.
And intra-abdominal infections.
For intra-abdominal, you need good anaerobic coverage plus gram-negative coverage. So maybe piperacillin tazobactam or a carbapenem like meropenem, especially if it's hospital-acquired or severe.
So the source really dictates the initial approach.
Absolutely. And you always have to ask, does this patient have risk factors for MRSA? If yes, add vancomycin or linezolid empirically. Do they have risk factors for Pseudomonas or other highly resistant gram-negatives? If yes, ensure your regimen includes strong anti-pseudomonal coverage, like cefepime, piperacillin tazobactam, or a carbapenem.
Okay, that makes sense. How long do you typically continue antibiotics?
The average duration is often around 7 to 10 days, but it really varies depending on the site of infection, the pathogen, how quickly the patient responds, and whether the source of infection can be controlled.
Source control? Like draining an abscess.
Exactly. That's critical too. You need to identify and contain the infection source whenever possible. That might mean removing an infected catheter, surgically draining an abscess, or debriding infected tissue. Antibiotics alone might not be enough if there's a persistent nidus of infection.
Right. Antibiotics plus source control.
Yes. And one more thing about antibiotics and sepsis. The patient's physiology is often dramatically altered.
How so?
Well, that massive fluid resuscitation we talked about can increase the volume of distribution for many drugs, potentially making standard doses less effective initially. And conversely, kidney function can change rapidly, sometimes improving, sometimes worsening, which dramatically affects the clearance of renally eliminated drugs.
So drug levels could be unpredictable.
They can be, which means you need to reevaluate the antibiotic regimen daily, assess clinical response, check culture results as they come in, monitor kidney function, and adjust doses or drugs accordingly. It's very dynamic. The goal is always to narrow therapy, de-escalate as soon as you can based on culture data. This prevents unnecessary side effects, reduces resistance pressure, and cuts costs.
Daily reevaluation and de-escalation. Key points. Okay, quick true-false for everyone. Antibiotics should be delayed until blood cultures are completed. That one is definitely false. Get the cultures, then start those antibiotics ASAP within the hour. Now, as any of these practice pearls or explanations are helping things click for you, maybe solidifying some concepts, please take a second to like this deep dive and subscribe to the channel. It helps others find this content and keeps you connected for future breakthroughs. So we've covered the big three: fluids, pressors, antibiotics. What else is involved in managing these incredibly sick patients? What about supportive care?
Yes, the adjunctive therapies. They're really important for comprehensive care. Corticosteroids are one that always comes up.
Steroids in sepsis, is that standard?
It's a bit controversial, or at least the evidence isn't rock solid. Current guidelines suggest using low-dose intravenous corticosteroids, typically hydrocortisone, around 200 milligrams per day, but only for patients with septic shock whose blood pressure is poorly responsive to fluids and vasopressors.
Only for refractory shock.
Yes, it's a conditional recommendation with low certainty of benefit. The idea is that some patients might have relative adrenal insufficiency during critical illness. Steroids aren't for every septic patient. And interestingly, the old practice of doing an ACTH stimulation test to decide who gets steroids, that's no longer recommended.
Okay, so hydrocortisone maybe for refractory shock. What else? Blood sugar?
Yes, glycemic control is important. Hyperglycemia is common in critical illness and can impair immune function and worsen outcomes. The goal is generally to maintain blood glucose levels between about 140 and 180 milligrams per deciliter.
Not super tight control then.
No, aiming for really tight control, like normal levels, was found to increase the risk of dangerous hypoglycemia without clear benefit. So the target is moderate control, usually using an IV insulin infusion if glucose levels are persistently above 180, with frequent monitoring.
Okay, 140 to 180 for glucose. Nutrition. These patients must be burning through calories.
They are. Their metabolic demands are huge. Early enteral nutrition feeding through the gut, either orally or via tube, is recommended whenever possible, usually within the first 24-48 hours. It helps maintain gut integrity and provides needed nutrients.
Enteral first. What about 5e nutrition, TPN?
Early parenteral nutrition, given alone or even combined with enteral feeds early on, is generally not recommended. It hasn't shown benefit and might even increase infection risk. Gut feeding is preferred if the gut is working.
Got it. Gut first. What about preventing blood clots, DVTs?
Absolutely essential. Critically ill patients, especially septic ones, are at very high risk for deep vein thrombosis and pulmonary embolism. So DVT prophylaxis is recommended for virtually all septic patients, unless there's a strong contraindication like active bleeding.
What kind of prophylaxis?
Usually pharmacologic prophylaxis with low-dose unfractionated heparin or a low molecular weight heparin like enoxaparin, often combined with mechanical prophylaxis like sequential compression devices on the legs.
Heparin plus SCDs. Okay, and stress ulcers, are they a big risk?
They can be. Factors like being on mechanical ventilation, coagulopathy, shock, and maybe high-dose steroids increase the risk of stress-related mucosal bleeding in the stomach. So stress ulcer prophylaxis, or SUP, is recommended for patients with these major risk factors.
What do you use for SUP?
Typically a histamine 2 receptor blocker like famotidine or a proton pump inhibitor like pantoprazole or meprazole. But it's a balance.
A balance.
Yeah, because reducing stomach acid might slightly increase the risk of things like ventilator-associated pneumonia or C. diff infection. So you weigh the risk of bleeding against the risks of prophylaxis, and typically only use SUP in the highest risk patients, stopping it when the risk factors resolve.
Makes sense. One last area: sedation for ventilated patients.
Right. If a patient needs mechanical ventilation, they often need analgesia for pain control and sedation for comfort and safety to help them tolerate the ventilator. The goal is to use the lightest level of sedation possible.
Light sedation. How do you manage that?
Using sedation scales to target a light level and often employing strategies like daily interruption of sedative infusions, wake-up trials, or just systematically lightening sedation regularly to assess the patient's readiness to breathe on their own and minimize drug accumulation. Pain control first, then sedate only as needed.
Okay, that covers a lot of supportive care. Let's do another quick listener check. Which lab trend is often monitored to assess improvement in tissue perfusion during sepsis resuscitation? If you thought about lactate clearance or the trend in lactate levels decreasing over time, you're absolutely right. That indicates perfusion is improving. Now, we focus mainly on adults. Are there major differences when treating children with sepsis?
There are some important distinctions, yes. While the overall concepts of sepsis and septic shock are similar, the specific vital sign thresholds, heart rate, respiratory rate, and white blood cell counts used in the definitions are age-dependent in pediatrics.
Age-specific criteria. Makes sense.
Yeah, a heart rate that's normal for an infant would be highly tachycardic for an adolescent. So you need age-specific charts.
Any key treatment differences?
One notable difference is in managing toxic shock syndromes, often caused by staph or strep toxins. Children can be particularly susceptible because they might not have pre-existing antibodies to these toxins. In refractory toxic shock, besides fluids and pressors, guidelines often recommend adding clindamycin to the antibiotic regimen.
Clindamycin specifically. Why?
Because clindamycin is thought to help by suppressing toxin production by the bacteria in addition to its antibacterial effect. Antitoxin therapies might also be considered in some cases.
Interesting. Clindamycin for toxic shock. Anything else pediatric specific?
Well, currently there aren't specific recommendations in major guidelines for routine DVT prophylaxis or stress ulcer prophylaxis in pediatric sepsis patients, unlike in adults. The risk-benefit balance is considered different, though prophylaxis might still be used in certain high-risk pediatric situations.
Okay, so some key differences, especially with definitions and toxic shock management. Good to know. So let's try to bring it all home now. We've journeyed through a really complex and critical area today. We've defined sepsis not just as infection, but as that life-threatening organ dysfunction from a dysregulated host response. We hit septic shock needing pressors, plus high lactate despite fluids. We talked about spotting it, maybe using QSOFA as a quick flag checking respiratory rate, blood pressure, mental status.
Right, those bedside clues.
And then the absolute urgency of that 1-hour bundle. Getting lactate measured, drawing blood cultures before antibiotics, but then getting those broad-spectrum antibiotics in immediately.
Crucial first steps.
Followed by that initial 30 millimole per kilogram fluid resuscitation with crystalloids and starting vasopressors, usually norepinephrine first, if the MAP stays below 65 after fluids.
That initial hour is make or break.
Then we touched on tailoring antibiotics based on the likely source pneumonia, UTI, intra-abdominal, and the importance of local resistance patterns, plus daily reassessment and de-escalation.
Yeah, hitting hard, then refining.
And finally, all that crucial supportive care, thinking about steroids for refractory shock, managing blood sugar, starting enteral nutrition, DVT, and stress ulcer prophylaxis for those at risk, and minimizing sedation.
Putting all the pieces together.
The core message, the thing we really hope sticks with you, is just how vital speed and appropriateness of therapy are in sepsis. It truly is a high-stakes field where knowledge directly translates into saving lives.
It really does. And maybe a final thought to leave everyone with. We talked about guidelines and protocols, which are essential. But we connect this to the bigger picture. Given how complex and fast sepsis is, how might a deeper understanding of individual patient risk factors, their genetics, their comorbidities, and those really specific local pathogen resistance patterns, how might that help us further refine these life-saving strategies? How can we personalize this even more in real-world practice?
Right. That's a great question. Moving beyond the protocols to truly individualized care based on deeper data, something definitely worth thinking about. Well, thank you so much for joining me on this deep dive through sepsis. It's definitely one of the most intense, but also one of the most rewarding challenges in pharmacy and medicine. If this helped you learn something new today, or maybe feel a bit more ready for an exam, please do consider subscribing to the channel. Perhaps share this with a friend or colleague who might benefit, or leave us a comment, let us know what topics you'd like us to tackle next. We're really trying to build something special here, a community of focused, kind, and capable pharmacists and healthcare professionals. Let's keep learning and growing together. Until next time, stay curious, stay grounded, and keep going. You absolutely have got this.